Dr. Lydia, thank you for taking the time to speak with me. I'm working on a piece on the issue of medical aid in dying slash assisted suicide. I was reading up on your bio, and you have quite the CV. You are the Dorothy L. and Daniel H. Silverberg Professor of Medicine at the Columbia University Medical Center, and you're the Director of the Center for Clinical Medical Ethics, and you're Co-Director of Clinical Ethics at New York Presbyterian Hospital, Columbia University Irving Medical Center, as well as being a practicing internist and ethicist, and you focus on end-of-life issues. And you've authored the book The Lost Art of Dying and edited Dying in the 21st Century. So, what was the impetus for your writing this book, The Lost Art of Dying? And what's the lost art of dying if none of us gets out of this life alive?
That's a great question. So, I wrote the book, The Lost Art of Dying. It sort of is the culmination of a lot of my work of the previous maybe 10 or 15 years on the preparation for death. As I was training in medical school and then as a junior doctor, I realized that so many patients die in ways that often they, as they're going through it, or their families subsequent to their deaths, express regret about. And so it seemed to me that the way we go about dying in this country in particular is highly medicalized. People are ill prepared. They arrive to the hospital almost with this sense that, they shouldn't be there. They should never have to die. It's kind of this total lack of preparedness. And I started wondering how, people died forever, right? So how is it that people have anticipated and prepared for death in the past? And in my sort of pursuit of answering that question, I stumbled across this genre of literature called the Ars Moriendi, which is Latin for the art of dying. And it was a very popular genre of literature for more than 500 years in the West, sort of all over Western Europe, spread to the so-called New World, and adopted by different religious groups and even non-religious groups. So it became this kind of, it really was an art. This is in the period of people learning the art of conversation or the art of table manners or the art of wielding a knife. Similarly, there was this art of dying that became very popular, and people just knew they couldn't get out of life alive, as you said, and they needed to anticipate and prepare. And this was really a handbook that was meant to be kept at the bedside for every person to be able to anticipate their death. And the central thread, I would say, to all of these different iterations of the Ars Moriendi is that if you want to die well, you have to live well, that the two are very much intertwined. And dying well, we think of restored relationships, spiritual peace, having gotten your earthly stuff in order, your material possessions in order, all of these things. And I would add to that the medical component, having an understanding of what's going on physically and how to engage wisely with the medical system. Those things kind of converge to give someone a good dying and a good death, but they are also important to a good life. And so that's the kind of central message of the Ars Moriendi. So I wrote this book, The Lost Art of Dying, for my patients, really, to help them be able to anticipate and think about living well in order to die well.
And would some of these patients be older Americans?
Well, yes. On the whole, as a primary care doctor for adults, the majority of people who come to my office regularly are older, sort of the retiree age, certainly over 50, but more in the retiree age. Those are the people who come in regularly. As an adult medicine doctor, I'll get the occasional 20-year-old, but she might not show up again for a few more years, whereas my older folks are coming in every few months. So yes, it does end up being, even though I'm not a geriatrician, the majority of my clinical practice has been with an older population.
And what drew you to the field of ethics in particular?
Oh, well, I'm not really a math and science person, and that's who usually goes into medicine. I'm much more of a humanities person. I was a debater in high school and college. And so when I found myself in medical school, I was at the University of Chicago, and it felt like an ill fit. I could do the math and science just fine. It was all fine. I wasn't as passionate about the science as I was about the human aspects of medical practice. And in ethics, I found the ultimate application of the humanities to medicine, because ethics as it is practiced is very interdisciplinary. So we are often engaging legal scholars, religious leaders, social workers, the nursing team, the patient advocates. So it's a really diverse group of people coming together to weigh ethical questions for which the answer is not patently obvious. And we're weighing those questions for usually a high stakes reason. In medicine, it's often a life and death question. And so as a debater, I loved batting around the theoretical questions, and in medicine, debating these ethical questions where they're not theoretical. This is actually someone's life is at stake, and we need to think about what is the best way we can care for this patient, given his or her own preferences, idiosyncrasies, social situation, etc. What does the law say? What does religion say? What does convention dictate? How do all of these things come together? So that's where, when I found ethics, and at the University of Chicago, there's a very, very large, well-funded, well-regarded ethics center. And I got involved there as a first-year medical student and really never looked back. So in terms of kind of my intellectual home in medicine, it's always been ethics since I started medical school.
I see. Seeing that your scholarship focuses on end-of-life issues, let's talk a little bit about the issue of medical aid in dying. Some people think of it as assisted suicide, some think of it as physician-assisted suicide. And Chris Palmer is an author. He has written the book Achieving a Good Death, and he's an end-of-life activist, and he covers this issue in detail. So really, could there really be something as a good death versus a bad death?
Well, I mean, it's tricky, right? We're in this culture of everyone thinking they can control all these aspects of life that ultimately might not be controllable. So I think sometimes of the way people put together their death plans as being analogous to the way people do wedding planning or birth plans. And I'll just say it's good to plan. I'm not against planning. I think it's great to sort of lay out what your goals might be and how you hope to go about it. But everyone knows that life throws you curveballs, and you can't be so fixated on your birth plan, say, that if it doesn't go exactly according to plan, that you get all bent out of shape. And I think a good death, planning for a good death, is similar. I actually don't usually use the phrase a good death. I use the phrase dying well, because I think they're slightly distinct. Dying is more of a process. Death is the very, very end. There's some question of when do we actually stop living and begin dying? I said around age 30. I don't know. I don't know that there's exactly an answer. But to the extent that you can get your proverbial house in order with the several things I laid out earlier in our conversation, the sort of having a grasp on and an understanding of the medical situation, having your relationships at a place where the relationships that matter most to you are in good shape, in good standing, working through these existential questions, the questions, why am I here? What is life for? What happens when I die? I think people need to come to some sort of peace about those questions, and that's part of living well and dying well. But sort of applying a label of a good death to an event strikes me as slightly strange, and in a sense it quarantines off the moment of death from the rest of one's living and dying.
So, with the issue of medical aid in dying, are we sanitizing an issue by calling it medical aid in dying, as opposed to what an opponent might say is assisted suicide or physician assisted suicide?
Yeah, I mean, it's important to understand that until recently, even advocates of legalization of so-called medical aid in dying called it physician-assisted suicide. So here I'm thinking of Judge Richard Posner, a big advocate of assisted suicide. He would call it assisted suicide. I'm thinking of the organization Compassion and Choices that used to be called Compassion and Choices is the largest advocacy organization in the US for the legalization of medical aid in dying. It used to be called the Hemlock Society, which was a nod to the ancient Greek philosopher Socrates dying by suicide, because Socrates died by ingesting hemlock, which is what caused his suicide, as a poison. So I think it is, if you look at the history of this subject, medical aid in dying, only until recently was it called physician-assisted suicide by everybody on both sides of the issue. Now, why the euphemism medical aid in dying? Well, the biggest reason is that as a society, we have always been opposed to conventional suicide. If we see someone on a bridge about to jump or on a building about to jump, we do everything we can to stop the suicide. Why? Because we have said that as a society, we recognize that certain factors, often major depression, is what drives the person to suicide, and that is treatable. And we don't want to live in a society where we allow people to take their lives. So in an attempt to distinguish physician-assisted suicide from conventional suicide, there was a recognition of the need to get rid of the word suicide altogether. And if we are going to ask physicians, or in some jurisdictions, nurse practitioners or physician's assistants, to be the ones to prescribe a poison that a patient can take to die by suicide, then not only do we need to get rid of the word suicide because we're against suicide, but we also need to make it sound like a medical procedure. And that's where this acronym, which really came on the scene in 2016 when Canada legalized what they call medical assistance in dying. Canada started calling it MAID, medical assistance in dying. And the world, especially the US, sort of the advocacy groups kind of took that acronym on and started using it even for physician-assisted suicide. In Canada, I'll say you can die. MAID means either pills, lethal ingestion, which is what we have in the US in the jurisdictions where it's legal, or it means lethal injection. And in Canada, in 2024, 16,499 people died by MAID. The vast majority preferred lethal injection, where the doctor just runs the IV into the vein and they die, and the doctor basically kills the patient. They prefer that to having to take the pills themselves and kill themselves.
So, if someone is terminally ill and lives in a place where MAID is legal, I know it's going to take effect in New York in, I think, August, in Illinois in September. So, if someone, say, falls into the category of terminally ill with, say, fewer than 6 months to live, asks for a lethal prescription, how does that impact the doctor-patient relationship?
Well, it's interesting because I think physician-assisted suicide or medical aid in dying is analogous to clinicians as abortion. And what do I mean by that? Well, most doctors think that abortion should be legal, but most doctors don't want to provide it. And the case is exactly the same with medical aid in dying. Most doctors think that it should be legal, and most doctors do not want to provide it. Why is that? Well, there is something sobering, maybe even chilling about taking life. Clinicians really pledge. I mean, we don't take oaths in the same way. There's certainly nobody is taking the Hippocratic Oath in its original form anymore. But there's a sense that the art of medicine is a healing art. It's a restoring art. It's not an art of killing or making dead or facilitating suicide. And so there's something, I think, that gives probably human beings writ large pause about taking life or helping to take life. And so, yes, while people want access and most clinicians think you should have access, most don't want to participate because it really is antithetical to the art of healing.
So then, where do you draw the line? And from a clinical or an ethical perspective, are we opening the door to throwing away people who may be seen as disposable, like the elderly or the infirm?
Yeah, I mean that's such a great question. So there's so many different ways to think about this question, but what happens? So advocates would say, well, in every jurisdiction where this is legal, there have been no abuses. There are a few problems with that statement. One is that the death certificate does not report that lethal ingestion or lethal injection in jurisdictions where it's legal is the reason for death. So we don't have an accurate public record of people dying in this way. There's also no required follow-up for reporting sort of the circumstances of, we'll just stick with the United States with lethal ingestion, with the physician-assisted suicide. There's no required kind of follow-up reporting. There's no follow-up on the drugs. No one has to be a witness to how a patient with bottles full of poisons that they can ingest when they're ready, how that happens. We won't know if someone was forced to take those drugs. There's no follow-up on any of this. If someone dies in New York, I know the law for New York says that there's a strong recommendation that family members, if they find leftover bottles of poisons, that they turn them in. But there's no requirement, and it's hard to enforce. So we dispense these poisons to people to take when they're ready, but we have no idea what the circumstances are surrounding. So that's just sort of 101. Are there abuses? We don't know. No one's following up, and no one is observing, and no one is reporting. But then you can push this another level, not just knowing the particular circumstances, but now who is pressuring whom to take these drugs or to even ask their doctor for a prescription. And everyone says there are no abuses here, but as a primary care doctor, I cannot tell you how many times in jurisdictions, in states where this is illegal, I have had family members of infirm older patients come in and ask me to prescribe pills that they can give their loved ones to hasten their death. Or I have had adult children of infirm older patients come in and ask me how can they basically sabotage their mother's or father's medication regimen to hasten death. So, and this is in places where it's illegal to do medical aid in dying. So there is, when people are distressed and they see life as disposable, or they see kind of ushering grandma along is perfectly legitimate, there will be a lot of pressure to do so. I will say that recently The Atlantic reported in February of this year, a young woman, how old was she? In her 20s or maybe 20s, I think, who figured out how to game the system to get access to physician-assisted suicide drugs. And she lied. She said she had stage 4 ovarian cancer, which she didn't have. She had a really difficult upbringing and suffered some abuse and struggled with mental illness, but she was not terminal. But she figured out how to get the drugs and she ended her life. So those are kind of the lowest level, could there be abuses? But then you take this a few steps up and you think about what happens when we can no longer afford healthcare. Look, we're on the brink of that in this country. So now you can no longer afford healthcare. The insurers are going to be much more inclined to authorize drugs to hasten death than they are going to be to authorize $1 million drugs to delay death for complicated autoimmune or other conditions. When California first legalized, we saw some instances of this where insurers were recommending medical aid in dying drugs to chronically ill patients, but would not approve their very expensive infusions that they needed to stay alive. This stuff went to the press, and then the insurers in California backed down. But you can see from the standpoint of having to care for a population, whether that's on an insurance plan or a nationalized health service like in Canada, where there would be immense interest in figuring out how to kind of move older, expensive patients along toward death. There's sort of no no reason not to from a financial perspective. We also know that medical care in the last year of life is some of the most expensive. And if we can eliminate that last year of life, for many, many people, we will save a lot of healthcare dollars. And so you can just see at a macro level how that would be an issue. You can imagine a poor patient, let's say on Medicaid, or who is getting charity care at a large urban hospital. There would be a lot of incentive to want to hasten death for a patient whose life expectancy of 6 months or less, then they would qualify, and they're receiving charity care anyway, which is just a tax to the system. So anyway, I'm giving you lots of different examples, but these are all the reasons why nation opens the door to abuse every time. Whereas if medical aid in dying were to remain illegal, but on rare occasion, doctors were to hasten death in a way that was not killing, and that might mean deciding to forego treatments or withdraw a mechanical ventilator or something like that, withdraw certain kinds of life support, which is not considered killing because it's allowing the underlying condition to just the natural death to occur. That seems like a safer way to go to mitigate abuses that will inevitably follow from legalization. And in Canada, we see all these stories of people not being able to pay their rent, so they seek out medical aid in dying. People not being able to afford their medications or their health care, so they hasten death, etc. And of course, in Canada, you don't need to be terminally ill. You just need to be suffering irremediably as defined by you. And the doctors need to agree that you're suffering irremediably. And then you can go ahead and end your life, or the doctors can end your life for you. So that's just another potential abuse, I think, of legalizing hastening death.
So then how does one balance a patient's call for MAID versus a doctor's or nurse's right to object on moral grounds? And what about pharmacists that refuse to fill these prescriptions?
Yeah, I mean, I think no one, for such a controversial procedure that is antithetical to what it means to be a healer, no one should be required to participate. And I think that certainly goes for the clinician. The pharmacist that's a tricky question. And this is something that pharmacists, actually, I don't even know where it's at in the courts right now, because yeah, I would have to defer to legal scholars on the pharmacist and drug dispensing question, because I know it's come up also with birth control pill for pharmacists who don't agree with that, etc. I feel like the Supreme Court ruled on that, but that I'm just not going to say. I don't know. With regard to medical aid in dying drugs, I feel like there has been a little bit of pushback, but on the whole, pharmacists have been dispensing. The drugs usually come from special pharmacies called compounding pharmacies. So this is not your CVS. This is a pharmacy that is putting drugs together in unique ways. So it's already somewhat specialized. So I can't comment on the legality of pharmacists, but my guess is that will go through the courts too if it hasn't already. But for physicians and nurse practitioners, et cetera, there's always the opt-out. Now, the New York law does require that an arrangement be made for transferring the patient to a facility that will assist. How that actually plays out in individual policies, I think, remains to be seen. We implement in August, as you said, but there is a requirement that, for example, if a Catholic hospital says we're not participating and there's a patient who wants MAID and qualifies for medical aid in dying, then the Catholic hospital has to arrange for that patient be transferred to a facility that could provide it. So, and I'll just say, since you asked, many people do not think that is ethical, because it still makes you complicit in a sense. But I think that in a society, in a pluralistic society, where we need to both accommodate those who want to opt out and accommodate those who want access, because it is a legal procedure now, probably, that's just the pragmatic solution, even if many people still feel like it's morally problematic.
And with the current Hippocratic Oath, does it specifically say do no harm? Do they have those words in the oath?
Well, so the idea of first do no harm comes from Hippocratic writings. It wasn't exactly in the oath as such. The ancient Hippocratic oath, no one takes anymore in that form. So no one is taking the Hippocratic oath. There's a modernized version of it. But yeah, I mean, basically, there's no point in talking about the Hippocratic Oath because no one really takes it in its original form. And then modern versions there are myriad, there are lots of different versions of oaths that people take today. But the general idea of not harming patients has been around since ancient days, regardless of whether you pledge an oath. But everything we do to patients can also harm. There are always risks and benefits to particular interventions. A surgeon cutting someone open immediately raises the risk of infection and lots of other risks. But we do it because of the larger good of cutting out the tumor or whatever. And so, yeah, first do no harm is a mantra, maybe we could say, in medicine. But at the same time, we're always doing harm to patients, usually for a greater good. But since you brought this up in the context of medical aid in dying, there's no greater good that comes from killing a patient because the patient now is no longer with us. So what is the good that comes from that? Other than the patient's own cessation of being, but then can you prove that being dead is better than being alive? I think that's a difficult thing to prove.
So, with all these MAID laws that are currently in effect or about to take effect, do they have specific safeguards or do other protocols have to be put into place?
Well, I mean, they all have purported safeguards, which is that the patient can't be coerced into getting the prescription. But again, how do you ascertain that? The patient has to have mental capacity, but we also know that we're often missing cases of depression. The patient has to be able to change their mind, which of course they can. The patient has to be able to self-ingest in every U.S. jurisdiction where it's legal. Those things are all true, but as I said earlier, there's no oversight. There's not an accurate description of what happened in terms of their death on the death certificate. No one has to be there to witness it. No one has to follow up on the drugs dispensed. And what we see in every jurisdiction worldwide that has legalized some form of medical aid in dying, whether assisted suicide or lethal injection, every jurisdiction has liberalized, which means what initially begins as a safeguard, once legalized, is seen as an impediment to access, right? You call it a safeguard, I call it a barrier to access, and we need to eliminate barriers to access. And so there have been so many bills put forward in the U.S. to liberalize access, and some have passed and some haven't. But not just in the U.S., worldwide. I mean, in Canada, originally you had to be dying to qualify for medical assistance in dying. And Canada legalized in 2016. By 2021, nowhere in the country did you actually have to be dying to qualify. So so-called safeguards are always seen as barriers to access once medical aid in dying is legalized. And then they're liberalized because it's a barrier. It's not a safeguard anymore.
And what about minority communities? How would this impact communities of color, for example?
Well, I mean, great question. In Washington, D.C., which legalized several years ago, there have been very, 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 very few African Americans who have taken advantage of so-called assisted suicide. And the reason is because minority communities who have long thought to be seen and cared for equitably in medicine, right? We have lots and lots of studies that show that racial and ethnic minorities receive inferior care across the board in medicine, even in the 21st century. So these communities know what it's like to fight to be seen and to be cared for. And the last thing many of them want to do is to submit to being killed or to having to being committing legal suicide. That's not an interest when your people have had to fight for good care. And so it is interesting. Most of the jurisdictions where it's legal are majority white, California being an exception. and Washington, D.C. being an exception. And in Washington, D.C., there have been very, very few African Americans who've taken advantage of this. I mean, very few across the board. Fewer Hispanics, although I think that's also starting to increase. What happens is, as people become used to the idea of hastening death, and it's given this veneer of legitimacy from the healthcare system, they start to think of it as just another medical procedure and stop thinking of it as suicide. And that's a part of the marketing strategy of advocates.
So is this promoting a culture of death?
Yeah, absolutely. Absolutely it is. I mean, there's no other way to conceive of it, because you could say it's a culture of choice, but the choice is a choice for death. And so I think choice is just masking what actually with physician-assisted suicide or medical aid in dying, what's actually going on, and that is hastening death.
Dr. Lydia, is there anything else that you would like to add to this very important conversation today?
No, thank you so much for your interest, and I wish you all the best with this piece.
Dr. Lydia, thank you so much for your time. I really appreciate it, and I hope you have a wonderful day.
Thank you. You too.
Thank you. Bye-bye.
Grateful. Okay,
Bye-bye.
bye-bye.